Hi, I'm David Taussig. I'm a consultant haematologist in the Royal Marsden Hospital in London. My specialist interest is acute myeloid leukemia. I'm going to talk to you about the use of Venetoclax in adults over the age of 60 as induction therapy. For adults who are not fit for intensive chemotherapy, I think that the evidence is very strongly in favour of the use of the combination of Venetoclax and azatadine at the moment. The remission rates were superior with Venetoclax at 66% from the randomized phase 3 trial published in the New England Journal of Medicine by Courtney Donado. The remission rates with azatadine alone are 28%. And the overall survival is better, improving from 9.6 months with azatadine alone to 14.7 months with the combination of Venetoclax and azatadine. For adults over the age of 60 who are fit for intensive chemotherapy, I think it's a more difficult decision what choice of agent to use, but I think there are a number of subtypes of AML which would benefit from Venetoclax containing regimens. In particular, I think the AMLs which arise out of myelodysplastic syndrome or therapy-related AMLs are appropriate to treat with Venetoclax and azatadine. When you look at the remission rate from the Donado paper in the New England Journal, with Venetoclax and azatadine, CR and CR with incomplete recovery was 66%. If you compare that to the best intensive chemotherapy, which is liposomal daunorubicin from the phase 3 study by Jeffrey Lancet and colleagues in the JCO, the remission and CR with incomplete recovery was 47%. And the patients treated in the intensive therapy study were fitter and younger on average. The only caveat to that is that patients who'd been previously treated with azatadine were allowed in the intensive chemotherapy study where they were excluded from the Venetoclax azatadine study. I think the other group where Venetoclax and azatadine should be considered is patients with an adverse karyotype. The recent data from Rafael Itzikson, which presented the alpha data group, showed that if you have an adverse karyotype with TP53 mutation or RAS mutation, your outcomes would die with intensive chemotherapy. While this remains a challenging disease for whatever treatment option you pursue, Venetoclax and azatadine is, in my experience, less toxic than intensive chemotherapy. And given that outcomes are poor, whatever option you select, I would rather select a less toxic combination. I think the other group where Venetoclax and azatadine may be useful to induce remission are de novo AMLs, which have MDS type mutations as detected by next generation sequencing. I think there are some types of AML where I'd favour in the fitter older adult intensive chemotherapy, in particular core binding factor leukemia, AMLs with a high FLT3 ITD mutation burden, and AMLs that are monocytic, based on the work from Craig Jordan's lab suggesting that monocytic leukemias have dependence on MCL1 rather than BCL2, which the target is, which is targeted by Venetoclax. I think patients with NPM1 mutation respond well to either regimen, and there is a randomized trial currently ongoing in the UK to answer which is better, called Victor study. But I think either intensive or Venetoclax and azatadine are appropriate for that subgroup of patients with an NPM1 mutation. That's my brief summary. Thank you for your time.